Hello students, this video will be helpful for you to understand about fetal engagement in late pregnancy. Fetal engagement is an important concept in obstetrics that helps us to understand whether the baby is getting ready for birth. It refers to the stage in late pregnancy when the baby's head starts entering the mother's pelvic cavity. This topic is very important for nurses because it helps in assessing labor process and planning safe delivery. Understanding fetal engagement allows us to identify whether the baby and the mother's pelvis are compatible for vaginal birth. As nurses, careful assessment of engagement improves maternal and fetal outcomes. This lecture will help you understand the anatomy, mechanism, assessment, and clinical importance of engagement in simple terms. The objective of this lecture is to understand what fetal engagement means and why it is important in obstetrics care, and we will review the anatomy of the fetal skull and maternal pelvis to understand how they fit together. We will also discuss the mechanism of labor and how engagement is the first step in the process. You will learn how to assess engagement using abdominal and vaginal examination. We will also discuss factors influencing engagement and its clinical significance. By the end of this lecture, you should be able to assess, document, and interpret fetal engagement correctly in clinical practice. Introduction. Fetal engagement means the widest part of the baby's head has entered the pelvic brim. Usually this happens when the baby is in a head down position, that is cephalic position. Engagement is important because it shows that the baby's head can pass through the mother's pelvis. It confirms that there is no major size mismatch between baby and the pelvis. Engagement reduces complications and predicts smooth labor. It is also necessary before using instruments like forceps and vacuum. In simple words, engagement is like the key fitting into a lock before opening the door for delivery. Anatomy review. To understand the engagement, we must review the anatomy. The fetal skull has different diameters, and the most important one is the biparietal diameter, which is the widest part of the head. The maternal pelvis has three parts: inlet, cavity, and outlet. Engagement occurs at the pelvic inlet. As you can see in the picture, the pelvis picture, the round part is the round part which is no, drawn as a black color, okay, as a round one. Okay, that is the pelvic inlet, and it has 8 stations on the left side and 8 stations on the right side. So engagement occurs at this pelvic inlet. The relationship between the baby's head and the pelvic bones determines whether the engagement is possible. If the pelvis is adequate, the baby's head is well flexed, engagement happens very smoothly. So anatomy plays a major role in normal labor. So as you can see in the picture, the fetal skull diameters are represented, and the pelvis inlet is shaded as a black line, and the fetal position is also given here. Okay, we have all positions are in head down position. As you can see, head is down, but the occiput, the place where the occiput placed in the round part of the pelvis, plays a major role. So in the round part of the pelvis, as I said, you have 8 stations on the left side, 8 stations on the right side. So which part of the station the occiput correspond represents the position of the fetus. If the occiput is in the number 2 position or number 3 position in the left side of the pelvis, then it is called as occipito anterior. It can be right or left. Okay, if the occiput is placed in the 5th position, then it is called occipito transverse. If the occiput is placed in the 7th and or 8th position, then it is called as occipito posterior. Okay, So it can be right or left. So the anatomy plays a major role in normal labor. Normal pregnancy overview. During the third trimester, the baby grows rapidly in size and weight. The lungs will get mature, the brain will develop, the fat will be accumulated under the skin. Around 36 weeks, most baby turns into head down position. The mechanism of labor includes a series of movements that helps the baby to pass through the birth canal, and these movements are called the cardinal movements. Engagement is the first step of these movements. So without engagement, the rest of the labor process cannot progress properly. So these are the cardinal movements. Labor involves 7 cardinal movements: engagement, descent, flexion, internal rotation, extension, restitution, and expulsion. Engagement is when the head enters the pelvis. Descent means the baby moves forward. Flexion will reduce the head diameter. Internal rotation helps to align the head of the fetus with the pelvic outlet. Extension allows the head to come out. Restitution and expulsion completes the birth. So engagement is like the first step in a staircase. Without it, the other steps cannot follow. Okay. Definition and clinical criteria. Clinically, engagement is confirmed when the presenting part reaches the level of the ischial spine, called the station 0. In cephalic presentation, the biparietal diameter must pass through the pelvic inlet. During vaginal examination, if the head is at station 0 or below, it is considered as engaged. This means this measurement will help the doctor and nurses to assess the labor progress accurately. So as you can see in the picture, they are doing a pervaginal examination, okay, on either side of the finger, okay. In the pervaginal examination, the two fingers are inserted into the vagina, and either side of the finger there is a small bone protruding inward, that is called as ischial spine. So if the head touches the ischial spine, then it is called as engagement happened. Ischial spine is the station 0. Okay, above that is we will call it as minus station, and below, if the head comes below the ischial spine, we will call it as plus stations. Can be from +1 to +5. Okay. So if the engagement happened means when you do a vaginal examination, head should be at the level of 0 or head should be at the level of ischial spine. Then you can call, you can confirm that engagement has happened, and this is a very important measurement which helps the doctors and nurses to assess the labor progress. We will move on to the timing of engagement. In primigravida women, that is during the first pregnancy, engagement usually occurs around 36 to 38 weeks. In multiparous women who have delivered before, engagement may occur later or even during labor. This difference occurs because the abdomen and the pelvic muscles are more relaxed in a multiparous woman. Therefore, timing varies depending on the parity. Pathophysiology or the mechanics. So how the fetal head negotiates the pelvic inlet. So when the baby head meets the pelvic inlet, it usually enters in an oblique or transverse position. The flexion of the head occurs to reduce the diameter. Okay, the more the head is flexed, the more less is the diameter of the more less is the presenting diameter. Okay, the skull bones overlap slightly, and this process is called as molding, and this happens to adjust according to the pelvic shape. The sagittal suture aligns with the pelvic diameter. These adjustments helps the baby to fit through the pelvis. This shows how nature prepares the baby for safe delivery. Signs and symptoms. When the engagement happens, the mother may notice that her abdomen looks lower, and she may feel increased pelvic pressure and frequent urination due to pressure on the bladder. The breathlessness complaint often will be reduced, okay, will be reduced, and because the baby is moved away from the diaphragm, this is commonly called as lightening. These signs help the nurses to suspect engagement. So what all the signs, symptoms will be there for the mother? There will be nesting. She will prepare for the to receive the baby, and there will be lightening, and there will be discharge, and there will be rupture of membranes, and there will be contractions. We'll move on to the assessment method. Engagement is assessed by abdominal and vaginal examination. Leopold manuals help determine if the head is fixed in pelvis. If only a small portion of the head is felt above the pelvic brim, engagement is likely. Vaginal examination will confirm the abdominal examination findings. An accurate measurement is important for monitoring labor progress. So as you can see, we have to do both abdominal examination as well as the vaginal examination. We'll see the Leopold maneuver step by step. The first step of the Leopold maneuvers is a systematic method of observation and palpation to determine the fetal presentation and position, and are done as part of physical examination. It is performed after 24 weeks. And the first one identifies the fetal pole in the fundus. So as you can see in the picture, which part of the fetal pole, it can be head or it can be breech. So which part is occupying the fundus, we want to see in the first grip. That grip is called as fundal grip. This maneuver determines whether the fetal head or breech is in the fundus. A head feels more firm than a breech, and it is round, hard, and moves independently of the body. The breech feels softer and moves only in conjunction with the body. So if usually breech will be occupying the fundus in normal labor. Okay, in LOA is a normal position. In that we will have a breech in the fundus region. So breech, how we have to say, is after palpating, a soft boggy mass can be felt in the upper pole of the fetus, which indicates fetal buttocks. We'll move on to the next grip, that is called as umbilical grip. This maneuver locates the back of the fetus. The back feels like smooth, hard, and resistant surface. The knees and elbows will feel like an angular bumps or nodules. Okay, so one hand will be placed on the right side and one hand will be placed on the left side of the mother's abdomen. Okay, the left side will, you have to push the abdomen towards the left side, and using a right hand you will palpate from top to bottom in a using the finger pads. Okay, in a rotatory movement. Okay, if it feels like a C-shaped regular nodules or C-shaped curve, you can say that as a spine. Same way, using the right hand, push the abdomen to the left side, and using the left hand with the pads of your fingers, do a palpation in a rotatory motion from top to bottom. And usually in the right side there will be lumps. Okay, sorry, there will be irregular nodules. The irregular nodules is the one confirmatory palpation for saying it is that as the fetal extremities. Okay, the fetal extremities will be felt as a irregular nodule, while the back will be felt as a regular nodule. The third grip is a polyps grip. This maneuver helps determine which part of the fetus is at the inlet and its mobility, or which part is occupying in the downward, lower segment of the uterus. If the presenting part moves upward, so your fingers and thumb can be pressed together, the presenting part is not engaged. Okay, so we have to palpate it from the lateral. Use your both fingers, palpate on the groins of the mother from both sides. Palpate with your pads of the finger in a rotatory motion from lateral to medial. You have to come with both the fingers. Okay, if you are able to approximate your finger at the lower end, then the presenting part is not engaged. If your hands are, that means if your hands are converging, the presenting part is not engaged. Same way, if your hands are not converging, if your hands are diverging, then you can say the presenting part is engaged. Okay. Next, we have the pelvic rib. This maneuver is only done if the fetus is in cephalic position. Here it helps to identify how much is the degree of flexion. Okay, how much the attitude of the baby is flexed. We have to correspond with the occipital protuberance along with the sincipital protuberance. Okay, if your occipital protuberance goes down and the sinciput comes up, then you can say the head is well flexed. Okay. The position of the fetal brow should correspond to the side of the uterus that contains elbow and knees. Okay, if the fetus is in poor attitude, the examining finger will meet an obstruction on the same side. Poor attitude means both your finger are the same level. The occiput protuberance as well as inciput is on same level. In a single line means the head is not flexed, but the acciput protuberance should go down. Then you can say the head is well flexed. They'll move on to the fetal station. Fetal station is a measurement from minus pi to plus pi. The station 0 is at the level of ischial spine and it indicates engagement. Negative stations means the head is above the pelvis. Positive stations means it is below. This measurement is very important in documenting the labor progress. Relationship to labor onset. Engagement does not always mean labor will start immediately. Some women may remain engaged for weeks before labor begins. In other women's engagement occurs during active labor. Therefore, engagement alone is not a definite sign of labor onset. Factors influencing engagement. Many factors influence engagement such as parity, fetal size, pelvic shape, the fetal attitude, etc. A large baby or small pelvis may delay engagement. Hormones like relaxin also helps in softening the pelvic ligaments. So good flexion of the fetal head promotes engagement. So as you can see in the picture, before the baby drops, there is pressure on the diaphragm. Okay, after the baby is getting dropped, okay, once the engagement happens, the pressure is relieved. Pressure is put on the hip, pelvis and the bladder here. Okay. Clinical significance and labor progress. Engagement indicates that labor is likely to progress normally. Okay, an engaged head usually descends smoothly. Lack of engagement may suggest cephalopelvic disproportion. Therefore, engagement is a predictor of successful vaginal delivery. Engagement and delivery outcomes. Studies show that engaged head at term increases chances of vaginal delivery and unengaged head in primigravida increases the risk of cesarean section. Therefore, assessment of engagement helps in planning mode of delivery. So engagement is the first step in determining whether you will have a normal vaginal delivery or any other mode. So there is a risk of prolonged engagement delay this a CPD, malposition and dystocia. Okay. So disproportion between the head of the baby and the mother pelvis will cause fetus. What will happen because of this? The fetus head does not engage and it remains floating. Because of that, you may go for trial labor, and after that there will be prolonged labor and there will be second stage of labor, and that leads to fetal distress. If the fetal head remains floating, there can be malposition and that also leads to fetal distress, and there is a chance for premature rupture of membranes. There is a chance for uterine cord prolapse, and that also leads to fetal distress. These are some of the complications if the fetal head is not engaged, okay, due to various reasons. Engagement in multiparous women. If the engagement in multiparous women, the engagement may happen late because the tissues are more flexible. It is normal for engagement to occur during active labor in these women. So the nurses should not consider it abnormal unless the other risk factors are present. Fetal position and engagement. Fetal positions like occipito anterior favor the engagement. Occipito posterior or transverse positions may delay the engagement, and malpositions can cause prolonged labor. So the correct positioning improves delivery outcome. So occipito anterior is the always favorable position with the well flexed head. Okay, as you can see in the picture, the head is well flexed, the chin touching the chest. In the other picture, the chin is not touching. In fact, it is very much extended. In these cases, the engagement will not occur very soon, and that also leads to many complications. Clinical case examples. We'll see clinical case examples one by one. Scenario 1. Mrs. A, 23-year-old primigravida at 38 weeks of gestation, comes for her antenatal checkup. She reports that her abdomen feels lower and she can breathe more easily, but she has increased urinary frequency. On abdominal examination using Leopold maneuver, 1/5 of the fetal head is palpable above the pelvic brim. On vaginal examination, the fetal head is at station 0. The fetus is in occipito anterior position. Her pelvis is clinically adequate. So, explanation. Since this is her first pregnancy, engagement at 38 weeks is normal. The biparietal diameter has passed through the pelvic inlet, meaning that fetal head will fit into the pelvis. Occipito anterior position is the most favorable because the smallest diameter of the head will present. This is like a key smoothly entering a lock. Once it fits properly, turning the key, that is labor, becomes very easier. So what may be the outcome for this scenario? She will go into a spontaneous labor at 39 weeks. Labor will progress steadily with a good cervical dilatation and descent, and she delivers vaginally without any complications. The baby and the mother is healthy, and the baby is with good ABGAR score. So what we can learn is early engagement in primigravida usually predicts smooth delivery, smooth vaginal delivery. Case 2. Primigravida with unengaged head at term. Okay. Mrs. B, a 25-year-old primigravida at 40 weeks, presents with a mild labor pains. On examination, 3/5 of the fetal head is still palpable above the pelvic brim. Vaginal examination shows station -3. The fetus is in occipito posterior position. Contractions are present, but it is weak. What is the explanation? At term in primigravida, the head is usually engaged. An unengaged head at -3 station suggests possible cephalopelvic disproportion or malposition. So occipito posterior position increases the presenting diameter of the fetal head, making engagement difficult. So this situation is like trying to fit a slightly bigger ball into a narrow ring. It may get stuck or even require force. So what may be the outcome of this scenario? Despite augmentation with the oxytocin, descent does not progress. Signs of maternal exhaustion and fetal distress will appear. An emergency cesarean section is performed and the healthy baby is delivered. So what we can learn is unengaged head at term in primigravida increases the risk of cesarean delivery. Case 3. Multiparous woman with a late engagement. Mrs. C, a 30-year-old multiparous woman, G3P2, at 39 weeks presence in active labor. On admission, the fetal head station is at -2. Within 4 hours of strong contractions, the head descends to station +1. So what we can explain is in multiparous women, the abdomen and the pelvic muscles are more relaxed. Engagement may not occur until active labor. So rapid descent is common because the tissues offer less resistance. So this is like sliding a door that opens more easily after repeated use. Outcome, she has a more rapid, uncomplicated vaginal delivery within 6 hours of admission. So what we can learn is late engagement in multiparous women can be normal and does not always indicate complications. Case 4. Large baby with a delayed engagement. Mrs. D, a 28-year-old primigravida with a gestational diabetes, is at 39 weeks. Ultrasound estimates the fetal weight is 4.2 kg. On examination, the head remains floating at station -4. So how we can explain this is a large baby, that is macrosomia, increases biparietal diameter. If the pelvic capacity is not sufficient, engagement may not occur. This suggests that there is cephalopelvic disproportion. So it is like trying to pass a large suitcase through a small doorway and simply may not fit. So what may be the outcome of this scenario? Elective cesarean section is planned and surgery is successful. Both mother and the baby are stable. Learning point is large fetal size is an important factor influencing engagement and delivery outcome. Case 5. Malposition and affecting engagement. Mrs. E. primigravida at 39 weeks presents with the back pain and irregular contractions. On examination, it reveals occipito-posterior position with the station -2. So what we can explain this, in a occipito-posterior position, the fetal head presents with a larger diameter. The flexion may be incomplete and delaying the engagement. Internal rotation is required for vaginal delivery. So this is like inserting a spoon into a narrow bottle in the wrong direction. You must rotate it to fit properly. So with good contraction, so what may be the outcome of this scenario is, with good contractions and maternal positioning, that is left lateral and pelvic rocking, the fetus will rotate to occipito anterior, and after that the engagement will occur, and after that she will deliver vaginally. Learning point is malpositions can delay engagement but may correct with the it may be but it can be corrected with the proper management. So what we can conclude is engagement in primigravida before labor, usually there will be good prognosis. Unengaged head at term in primigravida, we have to suspect for CPD or malposition. Late engagement in multipara, it's often normal. Large fetus and small pelvis, there is a higher risk for chance for cesarean risk, and correct fetal position improves engagement and outcome. We'll move on to the nursing assessment. Nurses must accurately record fetal station and engagement findings. So documentation should include abdominal findings, station of the head and fetal position. Proper charting helps in communication and communication among the healthcare team members. So the yellow shaded portion represents the fetal engagement as well as descent of the fetus. Okay, the station of the fetal head. It's a part of the partograph, okay, where the labor is recorded, and the yellow part represents the fetal engagement and descent. Management includes routine monitoring and correct assessment. If engagement is delayed, further evaluation like ultrasound may be required, so referral should be considered if CPD is suspected. Partograph becomes a major role in case of management. You should know correctly how to mark the partograph, okay, including cervical dilatation and cervical descent of the fetal head, and what time you have to monitor, and when you have to take action, okay, when you have to refer, everything you have to know. Associated assessments or like ultrasound, it can confirm the fetal position and engagement when clinical examination is unclear. So it is helpful mainly in case of obese patients or doubtful cases. Combining clinical and ultrasound assessment will improve accuracy. So fetal engagement is the entry of the fetal head into pelvic inlet. It is the first step of labor and an important indicator of vaginal delivery success. Assessment includes abdominal and vaginal examination. Timing differs in primigravida and multiparous women. So proper nursing assessment ensures safe maternal and fetal outcomes. These are the references. So thank you all. I hope you understand what is fetal engagement. Okay, we saw what is fetal engagement, the introduction, the anatomy, the normal pregnancy overview, what is mechanism of labor, what are the clinical criteria, what is the timing of engagement, the pathophysiology, signs and symptoms, what are the assessment methods, okay, the 4 steps of Leopold manuals, okay, what are the factors that that affects the engagement like fetal size, pelvic shape, parity, the attitude, okay, position, everything. Okay, and we saw the delivery and outcomes and complications. What will be the engagement in multiparous women? Okay, and we saw many clinical case examples and nursing assessment and management strategies. I hope you all gained some knowledge regarding fetal engagement in late pregnancy. Thank you all.